what we can give you today is insight into the way that we use telehealth and some suggested tools and processes, and we're happy to share all of our tools and processes that we use. We can tell you a little bit about what worked and what didn't work. And perhaps, you know, with the correct instruments, like an aeroplane and a bit of training, we should all get to our telehealth destination safely. So just a little bit of background about who we are and Alfred Health and Caulfield Hospital in particular. So Alfred Health is a large metropolitan hospital in Melbourne, and we have 3 hospitals as part of our organisation. So the Alfred Hospital, and then Caulfield Hospital, which is where we're from, which is primarily subacute services, so rehab and aged care, inpatient and community, and we also have Sandringham Hospital as well. So we've been providing at Caulfield Hospital telehealth services for about 4 years. But in particular, these projects we're talking about today have been going since 2012. So the first one, as I said, is a project that we have titled Tele-rehabilitation, and the second one is based in our Cognitive and Dementia Memory Service, our CADAMS service, and so we'll talk about those 2 pilots. Both projects were designed to provide support and service to rural and regional areas, and both projects used similar tools and methods but had a different focus and outcome. So the tools that we have both used that were originally set up in the CADAMS project, we think are quite generalisable, so hopefully they'll be useful to different contexts that you might want to use them in. So first, and I suppose the final point there is to point out that both of these projects have been funded by the Victorian Department of Health, and that's probably an important point to make because it would have been very challenging to have done these projects without lump sum grant funding, because, well, particularly for one of the projects, you know, there's no MBS item number for it or anything like that. So we do recognise that we were lucky to have grant funding. So first, the Tele-rehabilitation pilot. So this is a pilot that I was involved in and members of our team, and is one that's still ongoing. So it was 2 6-month pilots. So we've got one that we did at the start of last year with Bass Coast Regional Health in Wonthaggi, and one that's currently in progress towards the end of its 6 months with Northeast Health Wangaratta, and I think we might even have Wangaratta on the line, so they might be able to provide some more input as we go along. As I said, they were funded by the Victorian Government, and in particular the Stroke Network. So both of these projects had a particular stroke focus in terms of the content of what we were delivering via telehealth. So the project aims that we had, and I suppose the reason I'm going through it as a project is that this is probably a different use of telehealth than a lot of other traditional, perhaps sort of one-off assessment. This was more about capability building within a facility. So we had a strong aim to improve the staff capability at the regional hospital. We were aware that some of these facilities have small rehab programs or perhaps new rehab programs, and so trying to improve their knowledge and skill, particularly in stroke rehab, was a key focus of this particular project, and using telehealth in a way that we don't believe had been used a lot in the past. Patient satisfaction, we wanted to make sure that patients didn't mind participating in telehealth, and also didn't mind the concept of having a second team involved. There were sort of 2 angles to that. And the final point of our project was to look at capability building in the facility such that people would refer to the facility and that they'd be more likely to accept them, perhaps some of the more challenging clients. So I suppose the first thing when you start a telehealth project, well certainly for me, I hadn't done telehealth before being involved in this one, was my first thought was, the technology. And I think you can often get caught up in the technology. And I suppose from our experience, we were really lucky in that it was really simple. And sometimes it can be really simple. Sometimes it can be really hard too. But I suppose not to necessarily think that it is going to be your biggest battle or that it's going to be an enormous hurdle to jump over. The point that we found out, I suppose, coming from a metro facility is that the regional facilities, such as many of you that are dialed in today, have a much better telehealth setup than any of the metro facilities and are much more used to using the equipment and using it as a medium. So it really is a collaboration in our in our experience, between metro and regional, and that there's a lot to be learnt in both directions. We used Polycom facilities, so these were existing facilities that we had in our facility, and likewise the two organisations that we worked with had compatible setups. So I suppose it was a point for us of using what existed and what people knew and what people already had, and that was a really good starting point. As time progresses, we may well change the platform that we use, but that it was a really easy way to get started and to get started quickly. And with 2 6-month projects, you had to get started quickly. We did have the advantage of having an IT resource at both ends to help us test it, and that was really important. And throughout the program of 6 months, intermittently, we would need their help again when we had small tweaks or hurdles. We found Polycom reliable and had good vision. Perhaps one of the challenges that we had was that from an audio point of view, it was very dependent on where you were hosting it from. So in one of our pilots, a lot of the telehealthing was done from a gym, so that we could assess clients and watch them moving and doing upper limb activities and various things. But it did mean that we had to put up with a bit of echo and other sound problems. So I suppose it's always a balance, looking at the right environment for the purpose of what you want to look at versus the best audio and visual quality that you need. The other disadvantage, obviously, is the Polycom setup couldn't be moved very easily. We're going to go into, later in the presentation, some of the different options for technology, and we've got Troy, who's a bit of a guru in this, going to go through those. So I suppose that's just our impression from a very layman's point of view as to the technology that we used and how useful it was in that first project about tele-rehab. I just want to walk you through now a little bit about the model that we used in tele-rehab, because it may be useful for people if you're thinking of setting up something similar. So we have what we called internally the 3 bubbles, and there are actually 4 bubbles, but clearly I can't count. The first one being about direct education, so I'll talk a little bit about that in a minute, but obviously providing specific education on stroke and other elements of rehab was a really important part of this project. The second part of the project was in regards to doing patient advice sessions. So this is where we had a patient in the room selected by the regional team, and we'd have a number of therapists and clinicians at the regional site, and likewise a number of clinicians at the metro site, and we'd use this particular client's challenges or issues as a talking point and as a point in which we could provide assistance, and I'll talk a little bit more about that in a second. And the last part of the model that we did was what we called rehab systems consultation. So we worked with the regional facilities to look at the ways that they were managing their rehab program in general. So as I mentioned before, some of our facilities were quite new to rehab, or perhaps felt that they had areas they needed to improve on. And so we looked at things like how were they managing interdisciplinary assessment? Did they have any interdisciplinary assessment? What about journey boards or daily briefs, or what sort of rehab models of care were they using? So we went through a process of visiting their facilities face to face, as well as talking via telehealth, and likewise we had a couple of visits from the facilities to our hospital as well, to try and work out where it was we wanted to fill the gaps. And that was a really important part of the project as well. And telehealth was really helpful in that, but you couldn't have done it just via telehealth. The face-to-face element of it was really important. So if I now go down to bubble 1, which was the education, and I'll just sort of touch briefly on this, and if people are interested towards the end, I can expand more. But essentially the education program that we did via telehealth was in 2 parts. So we had a structured program, and this was a really important start to telehealth for us, for our clinicians, and also for the regional hospital, is to do some basic sessions at the start on things like telehealth familiarity. So how does this work? You know, what's the etiquette around using telehealth, and how do we make it work for us? And I can talk a little bit more in a minute about what we actually did in those sessions. But having a structured I think it was around a 1.5 hour session around telehealth was a really important start. As part of the education, we did a survey of needs, looking at where the gaps were for the clinicians at the regional end, so that we could make sure we tailored the telehealth education elements to those needs. And we did use established toolkits quite a bit. So particularly looking at the stroke guidelines or the best care for older people guidelines, we used those as an initial part of some of the sessions to provide a framework for what we were talking about. So we didn't reinvent the wheel if we didn't have to. The second part of the education was more about that sort of flexible program responsive to the needs. So depending on what the clinicians identified in their needs survey and also what we saw and heard from the visits, we developed a number of education modules. So for example, in the current program that we're doing, we've looked a little bit about managing cognitive and behavioural issues. We've looked at upper limb electrostimulation and various other elements. In the previous, the Bass Coast one, one of our education modules was just about what slings they had. So they would hold up a sling and we'd go, that's a XYZ sling and it's used for this, and we'd show them how to use it and what hoist to put it on. So it can be very, very functional, or it can be a little bit more high level. And I suppose the point about the education was obviously it's important to use telehealth as a vehicle for upskilling staff, but it was also about getting the staff familiar with the equipment before we brought patients in, establishing some rapport between the two sites such that the regional site didn't feel like we were going over stuff they already knew or teaching them to suck eggs. So it was an important start to the collaboration that we were undergoing. And also so we had a joint understanding of terms, because obviously when you're working via telehealth, the feedback mechanisms you're used to are not quite so evident. So the patient advice sessions, and this is a model of the flow that we used for our patient advice sessions. And I'm happy to provide, if it's difficult to see the detail in this one, I'm happy to provide copies of it. But essentially, around 48 hours prior, we get the referral information. We had initially hoped that what we would be able to do is just get the referral information that already existed at the regional facility, i.e. they wouldn't have to write a new referral. They could just give us perhaps an assessment documents or admission documents or other documents that they had. But it became apparent that that wasn't very easy to do and we weren't going to get the right information. So we did set up our own referral tool. But I think in an ideal situation, you try to just use the information they already had there rather than adding to the workload. So we'd get the referral through. Obviously, the regional team would have to identify a client that was suitable. And then there was a process of talking with the client to make sure that they understood why telehealth was being used and what the session would entail and how they would be supported throughout the session. Certainly most of the clients we've had involved in the patient advice sessions have been elderly and not necessarily familiar with the equipment. And so it was really important to demystify what we were doing and make sure that it wasn't at all scary. Then we spent, at the start of the actual session on the day we were doing telehealth, we'd spend about 10 minutes, sometimes that was closer to 15 or 20, with a discussion with the clinicians, so the regional clinicians and the metropolitan clinicians, just having a general discussion about the referral information, about what the regional clinicians wanted to get out of this session and what they thought the main issues were for the client. It was also a really good opportunity to point out if, for example, the patient had difficulty hearing or other issues that might make telehealth a little bit more challenging. So that was a really important part of the process. And then we would bring the client in. In most cases, we would try to have the client have a carer there as well. And in all cases, we made sure that the client had what we termed a patient advocate, which essentially was someone who normally had done the client pre-brief and was there to support the client, repeat the questions if they needed to, just generally support them if they were finding the process challenging, or even if they weren't, just to provide them with someone in the room. So we would do the session and address any of the issues that were brought up by the regional rehab team, and that took anywhere between half an hour and 45 minutes, occasionally longer. And then the client and their carer would leave, and we'd have a short discussion confirming what our recommendations were. But most of the time that discussion afterwards was reasonably short, because we actively tried to have most of the discussion with the client present and engaging them as part of the conversation. After the session, a really important part was to do a debrief with the client. So normally the patient advocate would sit down with the client again and ask them how they found the session and check they understood what had gone on in it and what the outcomes were. And also from our point of view, we would have the regional clinicians send us a short summary of what they perceived the recommendations were, just to make sure that we all understood each other. And we would just send back a quick note saying, yep, that's correct, or no, point 2 was actually, slightly different. So that's the process that we would follow. I might just open, before we move forward, were there any questions about that particular process that we used? Or
Martin Dunlop here from CADAMS. I guess one of the issues in terms of the debriefing is sometimes decisions about rehab programs can be difficult ones, and if I just thought that the referring team should be there giving the sort of debrief directly to the client, particularly if it's saying, well, we don't think there's much we can do for you. I think that should come from the meta expert team, rather than saying that, well, what that team said was this. Do you understand?
Yep, absolutely. Look, I can absolutely agree with you. So in all cases, the treating team was still the regional team. We as a metro team were purely there to provide advice, but it was completely up to the regional team as to what they did with that advice. In terms of the client debrief, that was always done by the regional team, by someone face-to-face with the client. And normally that, in most cases, that's been the NUM, the nurse unit manager, that's taken the role of the client advocate and done the debriefing. But absolutely agree with you, and that was a really important part of the process of what we did in terms of rapport building and understanding what we were doing, is that we as a metro team were not there to come stomping in and telling people what to do, but purely to provide advice when asked or where we saw a gap. But yeah, certainly many of those tricky conversations, I'm sure, would happen outside of this one-off event with the client.
But I'm not sure whether I'm being understood. But for example, I mean, when we've had discussions with super specialist teams in Brisbane, and a client has been declined a service by that super specialist team, I would expect that super specialist team to say, well, look, we don't think that that we can help you, rather than have a discussion away from the client, and then the regional team is saying, well, what they said was this. Yeah. I mean, that may not come up very often in the sort of telehealth situations that you're doing. It can, and you deal with how would you feel about that?
Yeah, the model that we were using here was quite different, I think, than the sort of model you're talking about. So we weren't assessing clients in order for them to have access to our service. We weren't assessing clients for admission to our hospital. What we were purely doing was providing a service to the clinicians in their management of the client. So it wasn't a case of us accepting or not accepting this client. This was just us providing advice to the clinicians at the other end in terms of how they would manage the client. In none of these cases was there any discussion about whether this client should come into our facility or anything. It's very much a capability building model rather than a traditional telehealth service model. Now, the model that we're going to talk about next is probably more of that. So perhaps what we do, if we move on, and then we can have some more questions soon if we haven't answered that question properly. Okay?
That's fine. Thanks very much.
Great. All right. So I'll move on a little bit. We're hoping that I've neglected to mention, we won't be talking for 2 hours because you'll all be falling asleep, I'm sure. So we'll keep moving so that we don't take up too much time. So I've just got a rather busy slide here around the key documentation, and I suppose the reason I put this together is to point out that we did have to have a number of tools and resources put together in order to make this work, and if anyone wants to see any copies of these documents, we're more than happy to share them with anyone, which may provide a useful template for other people. But certainly there's obviously the referral document. If you start from the far left prior to the session, there's the referral document. We had another document underneath the client and family bubble there about providing information for patients and carers. So we had a one-pager that outlined what telehealth was and why we were using it and how it would be used. We also obviously had a patient consent to the process, and that was really important. And we also had a patient familiarisation document, which was more about here's what's going to happen in your session tomorrow. You'll be collected 10 minutes before your session. You'll need to bring your glasses if you've got any. More sort of the logistics of the session, I suppose. And so that was an important document as well. After the session, as I said, we had a post-session summary that the clinicians would complete. And also a confirmation of that coming from the hub or the metro centre through to the remote or regional centre. Because we were doing this as part of a pilot, we also had a number of satisfaction surveys which we used, which obviously you may or may not need to use depending on the purpose of what you're doing. But they're some of the key documents that we used, and as I said, we're happy to share them if anyone wants them. Some of the things that we learnt, I suppose, from doing the patient advice sessions, as I mentioned, consider using existing patient documents rather than asking regional teams to write, lengthy referrals. And the initial clarification of goals of the session prior to starting the individual telehealth session was really important because a couple of times we would find that the session wouldn't perhaps go in the direction we thought it was going to go because we hadn't clarified that properly. During the session, patient participation was really important, so we almost always, had the patient actively involved in doing something or showing us something. The role of the patient advocate was really essential, particularly to clarify things when the audio was not very good, because sometimes we would get an echo. And the role of a facilitator or timekeeper was important, just to try and keep the session to time, because as you would know with telehealth, it can be tricky sometimes to read those, signals of people looking at their watches needing to go on to the next meeting, and it's obviously a little rude having people coming in and out, so keeping to time was really important. We learned a little bit about room acoustics, and I think the balance between the purpose of, as I said, the purpose of the room, i.e. do you really want it in the gym, and the acoustics is something you really have to weigh up carefully. So for this particular project, our findings so far have shown that it did improve the knowledge and skill of the regional staff and that it was acceptable to patients being involved in telehealth. I think we only had one client who was not so happy with the process and probably wouldn't do it again, but the rest of the clients were quite happy with it. And certainly we believe that facilities now have a greater capacity to take, in this case, stroke clients. So it was a useful project. We've obviously done it twice now, and we'll hopefully be doing it again. We're just waiting on funding for that. But what I'm going to do now is hand you over to Liz, who's from our Cognitive Dementia and Memory Service, and she can talk about quite a different telehealth project that we did that, although using similar processes and tools for a different purpose. I'll hand over to Liz. Before I finish, did anyone have any other questions specific to that pilot? No? We might leave it till the end.
Just in terms of looking at people's gait or how they're performing tasks,
yep.
How did you find the quality that you're getting suited your purposes?
Look, we did generally found it was pretty good. So once the clinicians got used to the techniques of panning and zooming and you know, swiveling the camera to get where we needed to go, we certainly found that we were able to do that, and that's one of the reasons that we did stick with the gym in the first pilot, because we were able to, you know, watch them walking on the bars and do other sorts of gait assessments, you know, both zoomed in and panned out. So it actually worked reasonably well. Our physios were quite happy with what the sort of visual they were getting from it, and my understanding is the clinicians at the other end found it useful. So yeah, it was good. Even for some of the upper limb activities, I think it was reasonably helpful, you know, the reasonably sort of more fine motor activities.
And what about the speech pathologist? Are they using this actively as well?
Yes, so we had speech pathologists involved in this pilot. I know that were we to be doing you know, more sort of comprehensive assessments, we didn't go down that line of doing very large comprehensive assessments, but we certainly used the speeches involved in it to look at management techniques and in terms of managing particular challenges. I think that the jury's still out as to whether it would work for a larger comprehensive assessment, and that's probably an angle that we're going to look at in the future, in terms of whether we can actually provide the same level of service that a therapist in the room could provide. I'm not sure about that, but in terms of providing advice, it was fine.
And nursing?
Yep.
How are nurses involved in issues like patient handling and that sort of thing, do you think?
Yes, look, one of the big positives, I think, of this model, and I was more involved perhaps in the earlier model than the current one, is that nursing staff were very actively involved in it and drove a lot of it. And perhaps for some of the staff, I think for a lot of allied health staff, you know, rehab work is sort of what you're trained to do. It comes, you know, perhaps a little bit more embedded in your training. Whereas rehab nursing perhaps is a different angle than some of the nurses had previously had exposure to. And so we had primarily one or two of our rehab nurse unit managers involved in it from our end. And I think the combination of telehealth advisory, education, patient advice, combined with site visits, I think the site visits, particularly for the nursing, were really important. So we did do 1 to 2 visits to the remote site, and they would send a group of clinicians up to us as well, and often they were predominantly nurses that would come up. So I think it's not a standalone technique. I think you need to combine it with face-to-face as well.
Sure. Thank you.
Okay, all right, I'll hand over to Liz now, and we should have some time for some more questions at the end.
My name's Liz Rand. I'm the manager of the CADAMS. Now, for those of you, I note that there's not actually that many people from Victoria here. CADAMS is a Victorian government-funded clinic, and we've got them located all around the state. And it's a specialist diagnostic service. So what we do is we provide a very comprehensive multidisciplinary assessment for people that have got concerns about their cognition, and we work towards providing a diagnosis and recommendations, and they're referred on, so we don't provide ongoing management. So our project was really looking at the capacity to provide that assessment and diagnosis to remote and rural areas. Olivia Gobbo, our geriatrician, is going to get up and talk a little bit as well. I'm going to just talk a little bit about setting up the project first. And we've got Troy Bailey online, and he's from the Mildura Medicare Local, and he supported the project for us at that remote end. We weren't sure about this cartoon, but it sort of fitted the picture. One of the reasons this project went ahead is that there was amongst the coordinators of the CADAMS around the state, there was certainly an awareness that there were long waiting lists at most of the CADAMS, but particularly in the rural and remote areas. And also some teams were having difficulty accessing medical specialists and neuropsychologists in particular, and that was sort of adding to the waiting list time, and also just meaning that in some areas it was extremely difficult to get an assessment and access to those specialists. And then there was also an awareness that in some areas there were some new teams that were wanting support and guidance. So we're looking at all of those factors, and the Department of Health provided some funding for this initiative as well to try and improve access to CADAMS in remote and rural areas. Initially, even though there was this identified need, there was quite a bit of scepticism about whether you could use telehealth for assessment and diagnosis of cognitive difficulties and in particular dementia. It was a tool that hadn't been used widely, certainly in Victoria. One would argue that we don't have particularly remote areas in our state, but we do have a few. It's a 7 or 8 hour drive from Mildura down to Melbourne, or at least 4 hours to the next big sort of satellite town, which was Bendigo, and I'll get to that a bit later on. So there wasn't a lot of experience, and there was a lot of scepticism and perhaps fear about using the technology in telehealth. Another interesting thing we found is that some of the rural and remote areas were a bit reluctant to introduce telehealth because they thought it might reduce the likelihood of attracting a specialist to their area, so that if it was provided by a metro facility and the specialist could just link in via telehealth, then they were less likely to attract someone to that region in the future. We've actually found it might do the opposite. After doing a bit of scoping and surveying, we identified Bendigo, which is a fairly large rural town in Victoria, for those not from the state, and they were quite keen to proceed with piloting a project, and that CADAMS there was already providing an outreach service to Mildura. They were having some problems providing that service. They were having problems with flying the specialists up because of, often the flights would be cancelled, or there'd be issues with the transport arrangements, or the specialists would be called off onto ward work at the last minute, and so quite often sessions were being cancelled, and so they were quite keen to look at this telehealth model as an alternative, and so we decided we would partner with them to see if we could get something going and provide an example of how it would work. As with the other project, we met with the Bendigo and the Mildura teams face-to-face to start off with, and that was to so that we could get a really good idea of what processes and tools they used and what roles they already had in place, so that we could try and match that as much as possible, because we felt that was important, because even though they were wanting to go ahead with the project, the teams on the ground were still a little bit sort of hesitant and sceptical about it. And so we thought it was more likely to be accepted and successful if we matched their existing processes. It was a fairly lengthy process to get it up and running. We had to get a memorandum of understanding between all 3 sites, and I think that's something that you need to consider if you're doing something from service to service. It might be quite different if you're doing just a specialist to a GP clinic, but certainly because we were looking at regional networks as well as our own, we had to get a memorandum of understanding, and it was made even more complex by the fact that we had 3 sites. We had Mildura, which was Sunraysia Community Health, Bendigo Health and Alfred Health, to try and get all the legal teams to agree on the terms of that MOU. And we had to sort out issues about whose patient is it, and as Sarah was saying before, the patient remains the patient for the regional service, and we were coming in and assisting with that process, but they were ultimately a patient of Bendigo Health in this particular instance. We had to sort out where the medical records were sitting, issues around professional indemnity, who was going to do the data, because like all publicly funded services, there was lots of data that had to be collected, and who was going to pay for what, and so we couldn't get started till all that was in place. Once we got going, we had 3 clinicians in 3 locations. We had the geriatrician, Olivia, who's going to talk to you later, from Caulfield. We had a psychiatrist from Bendigo, and then we had a nurse from Sunraysia Community Health. She was already an existing CADAMS clinician. The psychiatrist from Bendigo and the geriatrician from Caulfield were new to this particular arrangement, but not new to those services. Bendigo had previously been sending up a one of their neuro rehab physicians prior to that for the face-to-face service. For the actual project, we had 28 clients. We did 15 fortnightly half-day clinics for 6 months, and we also did 4 face-to-face visits as well, so where the psychiatrist or the geriatrician actually flew up to see those clients that we couldn't do via telehealth. And the whole project was evaluated using a satisfaction questionnaire that staff, clients and families completed after each session. And overall, it was a very positive response. It was interesting that there was one particular session where we didn't actually have any vision, and staff were often a bit dissatisfied when there was a bit of a lag in the audio, or we didn't have vision. But on this particular day where we literally had no vision, the response from the client and carer that it was all fine, although it would have been nice if we'd had a bit of vision. So they're pretty accepting of any issues, perhaps more tolerant than we are. In terms of the technology, Troy is certainly going to talk about that in a lot more detail later. But we, as part of the project, we had to identify what IT platforms we were going to use between the sites, and that was a little bit challenging and daunting, but Troy and the Medicare local up there was able to sort that out with us. We were fairly keen to have a desktop situation if possible, so that we didn't have to move ourselves to different rooms and that we could just sit in our office and do the consultation. One of the challenges is that there was no real uniformity in what systems are used in various locations, so that if you're going to do it to a number of different locations, you may end up using different platforms to different services that you might be liaising with. And that will depend also on whether you want to join them as a host, if they're hosting the service and you're joining into it, or whether you have your own hosting service and then invite people to join you for the consultation. But I think Troy will go into that in a bit more detail. We didn't actually use a process where we went into clients' homes. We had clients coming into a consultation room in Mildura, which is set up for video conferencing. But ultimately, I guess in some circumstances you could potentially end up doing some, if you're just using desktop, going into some people's homes to do it, or they could go into a GP clinic. So in terms of our process, the CADAMS nurse in Mildura went out and saw the people face-to-face initially, and she did a workup, taking history, doing some screening, cognitive tests, and liaising with the referrer, the GP, usually to get pathology and imaging organised before people came in. And she used similar assessment tools and forms to what we use in our clinic, so they were then just forwarded to us. So rather than having a separate referral form, like in the rehab process, we've got just the same tools pretty much that come through, and she provides a lot of that background information and faxes it through to us, or a couple of days ahead, or sometimes on the day, depending on what's going on, so that we've got it available to us beforehand. The process you see on the screen here has been modified somewhat since we did the project, and I'll get Olivia to talk about that in a bit more detail, but this was the process that we flagged as the potential model to start off with. Basically, the elements are fairly similar in that there's the preparation time where you've got to have some handover and make sure you've got all of the information available to you prior to starting the consultation. Olivia and Kay at the other end spend a bit of time just pre-briefing before the assessment with any sort of specific information that she thinks is important for Olivia to know, and Olivia can clarify anything that's in the reports that have been sent. Then the patient and client come in, and the nurse stays with them during that consultation to facilitate at that remote end. where we differ now with the model is that after that assessment, and Olivia will talk about what she does in the assessment, the patient and family go outside for a little while the nurse and Olivia have a bit of a discussion about that assessment. Then the patient and family come back in and they do a bit of a feedback to them about the results of the assessment. And then following that, the nurse can provide a bit of a debrief and actually does any follow-up and referral processes that need to be done while the geriatrician is writing a report. In terms of the documentation, as I mentioned, it's fairly important to have all the information available before you start the consultation, and there's got to be an agreement in what sort of form that's going to take so that it's all readily available and you've got enough to know where you're starting from. It's also important to be able to determine from that whether it is needed to be telehealth or whether it won't be possible and you might need to do a face-to-face. As Sarah said, it's very important that at the remote end there's a discussion with the patient and the family about how telehealth works, what's involved with it and getting their consent for that. And then the other documentation is around, getting some documentation in the patient record at that remote end, and the specialist or doctor at the hub end, at the metro end, completing a report that then goes back up to the regional team and to the GP as well about referral and recommendations. So I'll just hand over to Olivia and she can talk a bit about what she actually did through the project, and then has anyone got any questions before we do that about the setup part of it?
Hi, I'm a geriatrician. I work in the memory clinic at Caulfield Hospital, and so I was invited to take part in this project. And as part of it, we did some background work to try and work out the utility of using telehealth for dementia assessment. As part of that, we initially started with a literature review where we went back over about the last sort of 15 years to look at what had been done in the area of dementia assessment using video conferencing or telehealth. And what we did find was, although there'd been quite a number of studies, they were all quite small and they were often case-controlled studies, so not providing us with particularly robust data that we could rely on. We also found that a lot of the early studies had a lot of problems with technical difficulties, and that was just part of the initial startup technology that was available 12 or 15 years ago. And so a lot of the testing was limited by those technological difficulties. For example, when the picture was very poor, it was difficult to use a test such as the clock face test because the people assessing the accuracy of the patient's response couldn't see the pictures clearly. So there were different ways of looking at that. For example, sometimes the results were faxed through to try and compensate for problems with the vision. But overall, there seemed to be a lot of problems early on with technology. More recently, there's been quite a number of studies which have actually looked at the diagnostic correlation between a diagnosis of dementia using telehealth versus a face-to-face diagnosis. And over time, it appears that although initially there were some concerns about whether the diagnosis was the same and whether the correlations were good enough, now that technology has improved, the feeling is that we can actually make quite accurate diagnosis of dementia over the telehealth, using telehealth, but there are recognised limitations. The tests that have been validated in the area of dementia assessment over the telehealth system are pretty much the basic tests that we use in dementia assessment anyway. There's been validation data on the mini-mental and also on the RUDAS and also on some of the other scores such as the Geriatric Depression Scale, some of the CAMDEX, the cognitive aspects of the CAMDEX, but that was a very small study. So there is some evidence that we can use these tests over the link and get good results. However, there's ongoing concerns, obviously, about the inability to examine patients, as one of our questioners was asking before. As part of the assessment that I did, we would invite the patient into the room. I would watch them walk into the room with their carer. If I had any concerns about their gait, we would actually zoom in and have a better look at their gait. We also did sitting and then standing blood pressures, but that was actually as far as the physical examination went. So clearly, if you have other concerns about other medical issues that could be contributing to their cognitive impairment, there may be issues around not being able to examine the patient. What we found on our assessment was that really preparation was the key to success in doing these assessments. It was very important to have very good administrative support, and that included at both ends. We needed to have a team that worked really well together. And I think, as Sarah was saying, the face-to-face visits that were part of the setup of this study were absolutely vital in producing that teamwork and that ability to understand what assessment tools Mildura and Bendigo have previously used and how we can incorporate them into the same assessment. So basically we picked up on what they'd been doing, and we didn't introduce our own paperwork. We did what they were used to using rather than getting them to do the assessment tools that we tend to use. So I think that that was important, that it was seen as a real collaboration rather than us coming in over the top and saying this is how we would like it done. It was also important to have access to the patient information before, and that was, as Liz was saying, I usually would have access to that before seeing the patient and have the opportunity to discuss any issues in that referral information prior to seeing the patient. So I think that that's really important as well. Obviously, road testing the technology was part of the process, and we have had our ups and downs, as anyone who's worked in this field knows. And for that reason, I've always stressed the need for a backup plan. And in fact, the last couple of telehealth sessions, we've actually lost the video and we've had to do them via Skype. But in fact, that has worked. And I think that that's really important, to be able to be flexible about what you do, that you're prepared to change the assessment depending on the patient's needs, change the tools that you use, and also sometimes change the platform that you use. I guess the other part of the setting up for us was that we also recognised that there were people who'd had more experience than us in working in this field, and we did talk to Eddie Scrivens from Cairns and Leon Flicker in Perth, both of whom who were used to doing dementia assessments over the telehealth, so that we were able to utilise some prior knowledge and not feel that we again had to reinvent the wheel. So practically, what did we do? Well, we always had the clinician who was the CADAMS nurse in the remote end with the patient. And really, when doing cognitive testing, that's absolutely vital. Sometimes if the audio wasn't clear, Kay would have to reinterpret my instructions. She would actually observe the patient doing some of the tasks, and then, for example, would hold the pictures up to the camera for me to then score them. And then at the end, when we were having our debrief and discussion together, we would compare scores on the cognitive tests just as a quality assurance process. We also used tools that were familiar to both of us, and we found that that it was much easier when we used tools that the patient could understand. So practical tasks, such as the letter writing task, which is part of the CAMCOG, those sort of tasks that a patient understands were much better than using more abstract tasks. And as part of it, about once every 3 months, I do go up and do a face-to-face session with Kay and with the patients. Obviously, on those occasions, she's not in the room with me because face-to-face I'm quite competent on my own. But I think it is important to just have that working time together, that networking, meeting the rest of the team. And there have been quite a number of patients that I have followed up in review appointments, either face-to-face or via the video link. Obviously, there are some patients who really it's very difficult to do a dementia assessment over the video link, and that would include patients with non-English speaking background, any significant hearing impairment, and often patients with very significant language difficulties. I found that they're much better off being scheduled for the face-to-face appointments. So we're lucky in that we've had that option to be able to direct patients towards what type of assessment suits them better. So I sort of tried to balance up the telehealth scorecard, basically looking at the positives. The patients really actually quite like it. I'm amazed at how flexible some of the patients are, and some of our clients are in their 90s, and they're quite happy to come in, take part in the telehealth. We explain how you go about it and explain about not talking at the same time, and they're very flexible, and it's actually easy to develop a rapport with them because they are so open. So that's been a really great part of the assessment sort of process for me. I also think that it's worthwhile in that we have been able to provide a service where it is not otherwise available, and people are very grateful to have access to a service that they wouldn't otherwise have, or if they were to have it, they would have to travel many hours. So it's at least sort of 8 hours down to Melbourne, or probably 4 or 5 to Adelaide. So it is important to patients that they're able to access these types of services in their own communities. It also has made us have very strong links with Mildura and also with Bendigo, and I've also developed quite strong links now with a number of the GP practices in Mildura, because I do ring up and discuss patients. We talk about outcomes, we talk about drug treatment, and I see that as an important role also as a part of an education process for them and for me to understand the difficulties of managing in rural and regional health, but also just to try and expose them to a bit more of what's happening at the sort of more at the cutting edge of what we're doing in dementia care. So I think that's been a positive as well. Looking at the negatives, obviously, if you've heard from Liz, it's a bit of it can be complex to set up a whole process, and I think our complexity was added to by the fact we were working with 3 services, not just 2. Definitely, we found that for dementia assessments, having a clinician at the remote end is vital. I think it would be quite challenging with our client population to do that without somebody there to assist them. We feel that there is an ongoing need for face-to-face visits, and also some of the medical indemnity insurance companies insist on that, although it does depend on which medical indemnity company you're with, but a number of them do have built into their insurance that there is a face-to-face component in a telehealth service. Obviously, I've mentioned that there are some patients who are unsuitable due to sensory problems, the fact that examination findings are limited, and the technological problems can often be quite significant. I'll just stop there and hand back to Liz, but I'm wondering whether anybody has any questions for me at this point.
Pesky Martin again from Cairns.
Yep.
What about capacity assessments? I mean, geriatricians are often asked to undertake capacity assessments, and I wondered how comfortable you felt about participating in a capacity assessment through this means.
I would have thought that it wasn't something that we specifically did, because we were, as CADAMS, we're service funded for diagnosis. So sometimes the diagnosis does include a capacity assessment, but I've not done any capacity assessments as part of our project to this point. But I don't see any reason why it would be more difficult than anything else, as long as you had available information about the patient's past history and other information available. I think it is something that could be done via the video link.
Right. And I guess the other question is, and again, I understand you're doing more a diagnostic service, but when you get into the issue of discussing the diagnosis and management, obviously this is a very emotional issue, and I guess in a telehealth situation, I'd be worried that I'd be missing signals from the partner health that you can see very readily, even if it's restlessness or something like that. I'd just be concerned that I'd be missing a lot of those clues from the other party, indicating that they were distressed or unhappy or angry or whatever. That you mightn't necessarily see in a teleconference situation.
No, and that's probably one of the reasons why we feel that we need to have a remote clinician in the room with them. And the clinician that we use is very experienced. She's not only the CADAMS nurse, she also works for the ACAS in Mildura. And part of her pre-clinic assessment is that she's usually gone out to the patient's home and done an assessment with them and with their carer in their home. Then she arranges to meet them at the clinic. And because of the time lag that we've had with actually getting patients seen, she's often been seeing patients a number of times, sometimes over a couple of years, because there hasn't been access to specialists care, or it's been very intermittent at Mildura. So Kay actually often knows these patients and their families very well, and that is really an added bonus. But what Liz spoke a bit about, how we've changed the sort of the flow a bit more, and what we do is I do the assessment with them over the link, then we ask the patient and the carer to wait outside while Kay and I have a discussion, then we bring them back in, give them the feedback, and then I basically sort of mute out, and then Kay spends probably another 10 or 15 minutes discussing with the patient and the carer about the diagnosis, about anything we've discussed about future plans, say medication, any follow-up requirements. And so she really has a great opportunity to follow up on any of those sorts of cues, and the fact that she's been in the room there during the assessment, she's been aware of what's gone on. So I don't think that with the way it's set up now that we're missing those problems. I think that if you didn't have a clinician at the remote end, there definitely would be a risk of that. Any other questions, or I'll hand over to Liz. Okay.
Oh, sorry, would I be able to ask a question?
Yep.
Yeah, I've just got a question about, it was that second point on your slide about neuropsychology. My name's Renee Solwick. I'm a neuropsychologist from Monash Uni. I'm just wondering, are there any future plans within your service to incorporate neuropsychology into your service, or where you're at with that question mark, I guess?
Okay, I might hand over to Liz, because it actually was one of the things that we covered in our literature review, which actually we could probably let you have copies of, because we did actually survey neuropsychologists, I think throughout Victoria, for their opinion about that. And at the moment, our neuropsychologist who comes up from Bendigo is not using telehealth. She's actually doing face-to-face assessments. Do you want to talk a bit more about that? I'll hand over to Liz to answer the specifics, though.
Thanks.
You've preempted our next slide, because can neuropsych assessment be done by video conference? Look, the survey actually went out through the clinical neuropsychology network, so it went around nationally, and we had quite a good response from that. And there was a lot of scepticism and wariness of using telehealth to do neuropsych testing in particular. In the literature review, we found that there isn't a lot of good evidence for doing neuropsychology assessment over telehealth. There's some literature out of the States, but if you look at that in more detail, they're taking a very battery-oriented approach to testing, whereas neuropsychologists in Australia use much more of a hypothesis testing approach, and so you've not necessarily got a list of tests that you're going to go through. You'll have some, but on the whole, as the assessment evolves, you're responding to that assessment and pulling out different tools. Well, just by virtue of that, it's going to make it very difficult, because you've then got to make sure all of those things are available at the other end and can be whipped out of the bag at the same time, sort of thing. The other issues were around, I think an earlier question was around looking at how people actually respond and picking up those nuances of their behaviour, and also in terms of, say, the quality of how they're responding to things, if you're looking at language too. So there wasn't a lot of good evidence for formal neuropsych assessment via telehealth. There's some work coming out for some specific tests. Aside from doing the survey and the literature review, our neuropsychologists also then did an audit of our neuropsych assessments. We've got 4 neuropsychologists on our team, which is a bit of a luxury, and we audited all of the assessments we'd done over the last 12 months and looked at, well, what tools and assessments are being done most frequently out of that grab bag that we might use in an hypothesis testing approach, and which ones of those have been validated, which ones haven't. Of those that haven't been validated, by just looking at the nature of the test, do we think they'd be possible to do? And there was a percentage of those that could, and we could certainly send you those results if you're interested. But there was certainly still some that we felt that would always be very difficult to do via a telehealth link. What you might end up coming up with is a sort of general number of tools that you could use, and for those it's a bit like the hearing impaired or the people with significant language disturbance. They're the ones, if you think they're going to need that, they're going to either need a face-to-face assessment or a follow-up top-up to do those additional assessments if there's more needed. But there might be sort of a base level assessment that we can come to, and that's something that we'd be interested in looking at, but we've got to find the funding to do that yet. Does that answer your question?
Yeah, thank you very much.
Yeah. Are you using it in your role?
We're currently in the process of applying for some funding in stroke, but more in terms of neuropsychological rehabilitation rather than assessment.
Yeah.
So, yeah, that's something potentially down the track, but not necessarily right now.
Yeah, I think the assessment part's probably a little bit more challenging. But certainly something that I think we're going to need to bite the bullet and look at in a bit more detail, because you're probably an even more scarce resource than geriatricians, certainly in some areas anyway. So that sort of is the second point in our slide, that can neuropsych assessment be done by video conferencing? The jury's still out. I think the other thing to be careful of when you're looking at the literature is the difference between cognitive screening versus proper neuropsychological assessment, where you're looking at normative data, and that can be the difference. So we did find evidence that there are some cognitive screening tools that can be used, and some of those are normed, but a lot of them aren't normed over a video conferenced sort of arrangement. So that may influence the results if you're using it to compare to a normative data. Our other question was, can medical specialists use video conferencing to diagnose dementia? As Olivia said, yes, they can on the whole, and are fairly confident in that diagnosis, and the literature supports that as well. And will everyone like it? Well, as I mentioned before, the patients and families absolutely love it most of the time, and they quite enjoy it, and they're certainly very grateful to get the service. The clinicians were also did like it, although they were more frustrated by technology problems if and when they occurred. And, I think, they will occur. It's just human nature. We all know about computers. They will let us down sometimes. But on the whole, as long as you've got a backup plan, we can get through the assessments. So in terms of sustainability, our model was successful, and it's got ongoing support, and so there will be ongoing funding for it, or is ongoing funding. It is an alternate way to use existing funds. We found that the cost of providing the service was roughly equivalent to providing a remote service where we had to travel. But it is more costly than having an on-site service if you've got clinicians on-site. By virtue of the fact that we had to have Kay, our CADAMS nurse, at the other end, she wouldn't normally have been in, as she isn't for face-to-face sessions. So it's an additional cost to have her sit in on the actual sessions. There's no additional cost in terms of her initial assessment and follow-up role, because that's as it was before. It's just the additional cost in having her sit in for the sessions. In terms of future development, we haven't used MBS items in our particular project because it was funded through the Department of Health and it's continued to be funded. But you could perhaps consider it if you weren't funded or if you wanted to expand the service further. And there would probably be further development opportunities in terms of second opinions and case conferencing to local clinicians, similar to the stroke model, in areas where there is an on-site service but they're needing a bit more advice for some of the more complex cases. We have a neurologist on our team who people refer to from all over the state, and so, you know, to have him available to provide a second opinion would be useful for some of the more remote teams, for those very atypical sort of presentations. Any more questions before I hand back over to Sarah? Nope.
Now, let's just do a quick overview of what we've learnt from these pilots. And maybe a couple more specifics from my point of view. I think in terms of the telehealth training, I did touch on it briefly at the start about how important it was to do telehealth training. But I suppose in terms of what we did and what points were important for clinicians to know, certainly that concept of demystifying the machine, of making people comfortable using it, ensuring that they knew how to do things like, you know, log on, that there were a number of people in the organisation that knew how to log on. And that's something we're still working on. It tends to be that it's just the project coordinator or just the patient advocate that logs on. But expanding that knowledge base, knowing how to zoom and mute and pan, and having a cheat sheet for all of those things so that people feel empowered to use it, and that the machine in itself or the platform in itself is not a barrier. Oops. So understanding how to manage the environment, so lighting, sound and vision. One of the things we have learnt is around the importance of having not too much going on in the background, so whether that's a notice board or you know, a mirror or something that's going to detract. It's best just to have a blank wall, and we've learnt that. We do, in our telehealth training with the start of our projects, we do a couple of sort of scenarios where we, you know, turn off the lights or turn on different lights or change the background or change the seating arrangement so that the clinicians at both ends can see what's better for them, because sometimes the picture that you see of yourself is not the same as what they see from their end. So using, you know, do some experimentation around your environment to get it working properly. The other thing around sound is obviously around, we've talked about acoustics, but I think in the CADAMS project, it might have actually been a different project, the experience of having a telehealth session happening in a consulting room and realising that the patients in the waiting room could all hear what was going on as well. So making sure that your sound is appropriate, that people outside the room can't hear, because you are generally talking at a louder volume than you would for a face-to-face consultation. Knowing your role, making sure everyone knows their role within the session, making sure you do have a chairperson or a timekeeper, and the patient advocate, as we've said, was really important. And some of that etiquette around telehealth that, you know, Sky did when we all first joined in today, around introductions, around letting people know what the timing of the session is, making sure that everyone's prepared and has their documentation with them and not shuffling around frantically for it. Making sure that everyone who is in the room is in front of the screen. So we've had a couple of instances where we've had people to the side of the telehealth screen. You're not actually sure they're in the room. So very important to make sure that all of those etiquette issues are covered, and that people, you know, have got their phones off, and that there's a do not disturb sign on the door, and all of those things that become amplified in a telehealth session over and above when you're doing a face-to-face. And a backup plan, as Olivia talked about. Really important to have technical support available where possible, or at least have another platform that you might be able to use, like Skype, or even just the telephone. But also be prepared to be flexible. If it's really not working, then you might have to abandon and reschedule. We haven't had too many instances of that, but we have had instances of that. Having a remote telephone, so having the mobile phone numbers of the people that you're talking to, simple things like that make it much more workable. And ongoing orientation and tools and plans. In the projects that we did for Tele-rehab, because they're only 6-month projects, generally we could do one lot of orientation and that would last for the whole 6 months. But obviously with an ongoing program where you've got change of staff, you need to have, you know, sustainability plans in place. You will come across barriers. We've all come across barriers. Some of them are technological, but some of them are not. Some of them are attitudinal, or people concerned about aspects of what you're doing, and so there are barriers that you need to work through. As we've talked about, technology fears and concerns. Some people think that it is going to be much more difficult or invasive than it actually is, so talking through those. In particular, we found that some of the nursing staff, both at the regional end and at the metro end in our project, were quite concerned about using the technology. So we're talking people through that. Perception of it being a second-class option. As Liz spoke to, the concern that they'll lose the business case for a real person if they've got a telehealth service. And I think, as Liz alluded to, there is potentially a belief that it does the opposite to that, because you can connect clinicians with a regional area and they might be prepared to do more face-to-face. Technology, obvious barrier. Costs. Now, for all of our projects, we've been very lucky with block funding, so it allows us to provide the project support, administrative support and clinical support. But if you're trying to do it on your existing budgets or with MBS items, it would be a lot more challenging to do for any of the models that we've discussed. And workforce, as we've talked about, we had coordinators at both ends, not full-time obviously, but that was really helpful in the setup phase and really important. And as we've all spoken about, that face-to-face element, you can't underestimate how important that is. And IT support. We haven't had to use a lot of IT support, but when you need it, you want it quickly. So it's good to have someone that you can call. I'm going to switch back to Liz now, because we're going to just head into a little bit more about the technology before we close.
I just want to go through a few other things that we needed to consider, because we were providing actual client assessments. So in terms of the medical specialists, you do need to check your indemnity. What we did was we actually got, Olivia had an honorary appointment to Bendigo, and so she was covered by the insurance by that service. But if you were doing specialist assessments outside of that, then you would need to pay a bit more attention to that. I mentioned the Memorandum of Understanding or a contract. I think, again, if you're going from facility to facility for a regular service, then that's going to be an important step that you need to go through. Our staff were on a salary, and so we needed to ensure that there was going to be regular work and predictable work rather than have nothing at all. So we needed to establish that in our understanding between the different services. And also to have an agreement about the roles and responsibilities of the different services and the different staff within that. You could have a fee-for-service model, but it would require quite a lot of good planning and consideration around your business model for realistic funding. There are Medicare items available, as you probably know. We are not an expert on those because we haven't had to rely on them. But, there is capacity to bill from both ends, so the specialist can bill and so can the person at the other end, if it's a GP or a practice nurse or a midwife or an Aboriginal health worker. They can use the Medicare items that you would normally use for that consult, and then there's a 50% top-up on top of that as a derived fee. But you need to be quite careful that the Medicare item you use as a base item is the appropriate item to be used. And the incentives that were put in for using telehealth actually finish at the end of this month as well. And so from here on, it'll just be the Medicare items that you can use with the derived top-up of 50%. In terms of the process and evaluation, as I think we mentioned, I think it is fairly important to try and mimic existing processes where possible. So using existing assessment and referral information and matching the tools and the assessments and processes that people use at the remote end. And there needs to be a clear understanding of who's gathering what information and what the roles and responsibilities are in that. It's very important to be flexible, as Sarah said, and be prepared to modify your approach as the program evolves, but also within any individual session, depending on what glitches you might come across. we tried to take a sort of what we call the 3 clicks approach, because if it's too different or too complex, then it won't be taken up. And one of the other things that we did very early on in our project is we got the skeptics on board straight away and gave them important roles, so that their perceptions of telehealth were changed fairly quickly. I think Olivia was a bit sceptical to start off with, and she came on board, and our neuropsychologist was one of the other skeptics, and she sort of was almost converted at the end. So be prepared to learn as you go along and modify and adapt as things are changing quickly. Even technology is changing, so we need to keep our eyes and ears open so that we can modify what we do as we go along. I'm not going to talk a lot about the technology. I think we've got Troy online, who has been a godsend to our project. We found, as Sarah said early on, that I think the remote areas, the rural areas, have a much better grasp of what IT systems are around and how to use them and have platforms available. And we certainly linked in with the Medicare local for that up in Mildura, and that's where Troy is from. I'm aware that the Medicare locals are perhaps about to be disbanded and made into primary health networks, and we're hoping that they'll continue to do the excellent work that some of the rural Medicare locals have done in relation to e-health. It would be a great loss if they don't. We've written there that Skype is not suitable. Ideally, you wouldn't use Skype, but if you've got a really good quality bandwidth and speed, then it can be used, and there are services that do use Skype, and we've certainly used it in some circumstances as a backup as well. There's a lot of resources available. For example, the RACP has got some really good telehealth startup guides, and we used those, and Troy's got some good stuff that he's put together too that we couldn't have got going without. So, you know, particularly if you haven't got project funding, there is actually quite a bit of information out there that can make it fairly simple to get started. You've just got to, you know, use what's already been there and what other people have learned by other people's mistakes, and we'll be providing you with a list of some of our resources later on. Now, Troy, are you online there and ready to talk to your bit?
Yes, I am.
Good. Welcome, Troy.
Thank you.
Yes.
Because what we found is there are a lot of options available to you to a scale of 1-to-1 and up until what we're doing right now. So really what's needed is, when you're looking at a project, I would suggest starting at the clinical outcome that you're trying to achieve, and then find the technology to suit that, rather than looking at the technology first and deciding within a budget or within the scope of a particular sales representative, because you'll find there's an option to salute every environment that you're in. So in this instance, we had 3 locations, a rural site, the Caulfield Hospital in Melbourne, and the Bendigo Health in Bendigo, and each 3 sites had differing requirements, differing standards. The larger hospitals really didn't want to use Skype, so then we had to come up with an alternative. So based on the needs of each end, you then develop a solution to cater to those needs. So in this case, we went with Video. The product that we're using right now is actually a product that we purchased as well, and provide free to any clinician that provides a service into our region. It could have very well been a number of products on the needs of each endpoint. So it's like what's been mentioned a number of times around doing your research, doing your homework. Before you go into anything like this, you need to decide what is the scope of your service. Are you connecting from point A to point B, or are you providing your service from point A to potentially any endpoint. And that will significantly change what product you use. So I think I would strongly recommend anyone that was looking really at any telehealth solution, even if it is only point A to point B, you really need to get some advice from people in this field, people with experience with telehealth, so that you don't end up spending tens of thousands of dollars on something you really don't need. Because from our experience in a rural setting, we've done quite a lot of telehealth using every possible solution that's out there, and we've found that with the proper support and simple things like a good quality webcam, we've had telehealth with Skype that are as good as any Polycom that I've seen. So with the right equipment and the right setup at each endpoint, you really can have a good telehealth consultation. With the project that we're referring to here, our biggest coordination aspect was actually the IT departments at each site. Without cooperation from the Caulfield Hospital, from the Bendigo Health, it would have just been impossible to have this work. So as much as you have cooperation between the clinicians at each site, I think there would have almost been as much conversation happening behind the scenes with the 3 different IT representatives for each site to check systems, to do testing, to make sure they had the best possible equipment within their budgets, and make sure that they were available at hand if any issues arose. So I probably wouldn't worry too much about the technical aspect, just to make you aware of the scale that I had in that table, where you can start with something as simple as Skype, which is purely software-based. It's free of charge, and with some good equipment, you can be up and running with telehealth within a day or two. It actually does work and works very well. But then what I've noticed is you then start to progress into more advanced systems, to what I would call a facilitated solution, whereby you are actually paying for a service, and that service is providing backup support, is monitoring the system for you, is facilitating it as we have today. So that becomes the next level, and that's for those that are getting more involved with telehealth and are prepared to start paying a cost towards it. And then interestingly enough, the final step, which we used to believe was the hardware devices, the Polycoms, the Tandbergs, where they're at the more expensive end of the market, we're actually finding that they're becoming less relevant in this environment, especially around clinical consultations. So we found with this this project that we had, the clinicians preferred to be sitting at their desk where they had their paperwork, they were in a more relaxed environment, rather than being in a large conference room where there was a large TV at one side of the room, and you didn't really have that feeling of eye-to-eye contact, which I think is very important when you're dealing with a patient in a consultation. They really do need to feel that you are talking to them eye to eye. And we found that the best scenario for that was sitting in front of a desk on your normal desktop and using, in reality, the more cheaper products that are on the market. So there are many options available to you. What's been mentioned before, I stress the points about having the right technology. Something as simple as a speakerphone You know, I have a special little microphone on my desk, which cost me $100. Not a large expense, just to help with the sound, the lighting in the room, you know, the quiet environment, and then the processes around making the consult happen. It's amazing to watch just how stressed people get when they're involved in a telehealth consultation. I think everybody's worried about holding up the other person. So it's just knowing how to relax the situation and having that backup option. Because with our service, we have had our issues, and the complication is knowing of the three ends, where is the issue. So we're quickly ringing each other and doing a lot of testing, but the communication between sites is vital. And I find that not all IT people are as conscious of the significance of a telehealth as well. We really need IT people who understand what we're trying to achieve here and will put themselves out to prioritise this sort of activity, because it is very important to have a response from an IT person at very short notice sometimes. So if you're looking for support, you need the right IT support, someone that's accessible at very short notice when you're about to start a session of 5 patient consults. But it'll work. I find in any situation, in any location, we can make this work. But I would stress again, you really do need support, someone that you trust in an IT background preferably, that has a lot of experience with telehealth, and they can make it work for you. So I'd encourage everyone here to try it or to continue doing telehealth.
Thank you, Troy. Yes, I'd like to emphasise that too. I mean, having Troy as a support in our project was sort of the make or break, I think, because, you know, in a big hospital network, certainly in a metro network, we didn't have a lot of IT people that knew a lot about telehealth or knew of the importance of the you know, the actual clinical interaction and the need to sort of get onto it fairly quickly. One thing I'd also say, though, that as the project has gone on, it's been a joy to watch the confidence with which the clinicians have developed their use of technology and actually troubleshooting themselves too. So what would have originally been a, oh God, we've got to ring Troy, perhaps now being troubleshooted a little bit by ourselves too, and, you know, even just walking into the room and getting set up, you know, by yourself. So that's been interesting to watch as well, that change in confidence. Just a couple of the resources. As I said, the RACGP have got quite a lot of good documentation around telehealth, and then the rural e-health service as well. And then we've got a list of quite a lot of other different resources that we found and accessed to that can be helpful if anyone's starting up a project. So, telehealth, it's just a different way of doing what we already do. On the whole, it's been a fairly positive experience. It's simply just a different tool for the same process. The tool and the process can be, as Troy said, as simple or as complex as you want to make it, and it doesn't necessarily have to be expensive. It doesn't completely replace face-to-face, but I think it is a very valuable tool to provide a service to areas that would otherwise not have received it, and can certainly provide a good service to a large number of our clients. And I think that's it. So we're open to questions.
Just around the technology, we use Jabber in our local health district. We're southern New South Wales, and what I'm told by our people, technical gurus, is that because it's encrypted and that we shouldn't use Skype because that's not. I'm just wondering if you have any comment about the security of the platforms that you're using.
Troy, do you want to answer that one?
Yes, in the early days, Skype was talked down quite a bit about the security, and I think the GP college had to come out later and reverse their earlier findings. The actual data that travels across the internet is encrypted with Skype, and I've seen the official paper from the New South Wales Health regarding why they don't allow Skype, and it's not, there are other issues that they bring into play.
Oh, okay.
Yeah, around not knowing who's using it, the effect that it has on their network. And with Skype, there is the potential, because certain information is stored on your local PC, that if someone was to hack into your PC, they would go for your videoing log before they went for your credit card details. I don't see where they would prioritise that. But it's certainly nowhere near as scary as some people are making out. But certainly New South Wales Health has been our biggest barrier to getting telehealth going.
Okay, look, thank you for that. And thank you for the talk. It's been very useful.
Any other questions?
Can I ask a question? Claire O'Connor from ACI. I just have a bit of a practical question, I guess, around documentation. Do you have a shared electronic record between your sites? Because we have some sites that are looking at doing telehealth that aren't yet on electronic medical record. So there's issues around how does that documentation get into the file, who signs off if the consultation is being done from one clinician to another at another service. Do you have any comments around that?
Yeah, it's a good question, and one that we had to deal with, because with the 3 sites, of course, there was 3 different ways of documenting. Certainly at Alfred Health we have got an electronic record. One of our other geriatricians did do a project to Goulburn Valley, and they were using the same electronic system for their medical record as we were, and that system worked very well because it was all just shared via that Cerner system was the system we were using. And so you could pull up, you know, the images and the results and, you know, progress notes, everything while you were online to the consultation. In our particular project, the CADAMS project, Bendigo had a paper record, although they are now moving to an electronic record, and Mildura certainly had a paper-based record. So we had to work within that because they were the systems that they had. They weren't big enough or wanting to necessarily come across to a behemoth like Cerner that we use and have problems with. So we had to have systems where we could get that information as a paper-based, or generally Sunraysia had a, which is Mildura, had a policy that they didn't like to email stuff, so it's actually faxed through to us.
Thank you for that. And in terms of your documentation back into their notes?
We do a report. Yeah, we do a report that is sent back to the GP, and a copy goes to the Bendigo Health and Sunraysia Health record.
Thank you.
But the main medical record is kept by Bendigo Health because they're the sort of the provider, even though the service is in Mildura, it's through Bendigo Health that it's being provided, so the medical record sits with Bendigo Health. And that's going to differ for every single project or service you set up, and it's one of the things, as I said, that you need to sort of sort out right from the get-go. Who's going to record what, where's the record going to be held, and how are you going to manage that?
So important to have that figured out in your MOU.
Definitely, it's a large part of our MOU, yeah.
Okay, thank you.
Hi, it's Tracy here. I just wanted to ask, who are the people that are actually the project officers at each end, or the coordinators?
For the CADAMS Telehealth project, I was partly responsible, but I actually employed one of our occupational therapists who had run a telehealth program for the movement disorders or Parkinson's group right back from 1970 something. So she'd been running a long time a Parkinson's neurology assessment and management service across Victoria and into Tasmania. So she had a lot of experience. So her name was Beth Kirkwood, and she ran the CADAMS project. And
in terms of the other two projects, without making it look like OTs are ruling the world, I do happen to be an OT by background. Both of our project officers for our two projects happen to be OTs as well. But it would have been suitable in our case for any clinician to have done, whether that be nursing or allied health or medical. But it certainly needed to be someone with a clinical understanding of the content, even though the content was delivered by the clinicians. The project worker needed to have an understanding of the context.
And Beth was a member of our actual team as well, so she had a very good understanding of what CADAMS was and what we were trying to achieve. And I think that was, you know, as Sarah said, crucial to who we appointed as the coordinator.
That's great, thank you for that. And can I just ask a question of Troy as well? When you talked to Troy about how there's needing to be more flexibility between point A and any other end point, that seems to be the case for our team. We need to be actually having point A and then accessing people at other points, which aren't necessarily near video conference Tandberg equipment. What sort of tools would you use for that situation?
Yeah, that's when you look at other options. So a Tandberg can't be installed at every site. So what I would look at is you need to see who's prepared to bend, or point A or point B. So you can't necessarily throw a Tandberg out to 100 sites, or can your site use a different product that you can have at 100 other sites? And what we did is these facilitated solutions, so that the system we're using now is web-based and you're logging in for free, but can also connect in polycoms. So if you have someone to help you, a service company, they could potentially provide this solution whereby you can continue using your Tandbergs, and at the remote sites they can log in on a desktop using video. So either you get this sort of solution or someone has to give. And if you really want it to work, it would be best if the specialist end accommodated the patient ends, but then you get hit by the IT department who says, no, we won't allow it. So that's where each endpoint needs to have this discussion. What are they prepared to do? What flexibility do they have? And how much are they prepared to spend? These solutions can be expensive.
And the other issue we face is that we're trying to do it with inpatients who are in hospital beds in a ward. So they're not outpatients,
This would be this type of product can work on iPhone, iPad, Android. So and again, that's where I would say, tell me what the clinical environment is, what is the outcome, and then we find the technology to do that. So there are a number of technologies that could do it, and tell me how much you're prepared to spend, and you can make it happen.
Thank you for that.
Can I just mention that the other project I mentioned, where one of our geriatricians was consulting to Goulburn Valley up in Shepparton, it was an inpatient ward round he was doing, and they put the computer on a trolley, and so he was a head on a trolley that walked around and saw people and did his ward round basically via telehealth. And that worked.
Thank you.
Any other questions? No, well, we might wrap up there. So thank you, everybody, and I'm sure that they've got our contact details here. They're up on the screen for you, or if you haven't got a copy of that, then you can probably contact the RACP here. And so if you've got any other questions, you can always contact us and we can see if we can help. Okay, thank you. And thank you, Troy, for joining in with us remotely.